Good morning, everyone. All right, we're gonna go ahead and get started because as usual, I put a lot of slides in here, more slides than I have time, and I want to make sure we can get through as much as possible. So my name is Adrienne Artis. I'm one of the child abuse pediatricians here at the hospital, and today I'm going to be talking to you really just about the Child and Adolescent Protection Center, Child Abuse Pediatrics. Though this center has been here a very long time, I'm still finding that people don't know that we exist and are located here in the hospital, and what exactly is it that we do, and when should you call us, and things like that. So today we're just going to really be talking about what is child abuse pediatrics, how can our team help with concerns that other providers in the hospital may have, and not a lot of medicine in this one, just a lot more explanations. So bear with me as we get through everything. So Cindy had asked me to participate in a Your Questions Answered lecture. And from that lecture, there were questions that seemed to be commonly asked. So she shared those questions from folks, and I attempted to answer them in this presentation. So you'll see the formatting in a lot of the slides. You know, there's information, but you'll see a question at the top. And when there's a question at the top, it's actually a question that was asked of me to answer. So that's why it appears that way. Okay, so the first question that surprised me the most, so I'll have it answered first, is do we have a special clinic for sexual assault care at Children's? This surprised me because I didn't know that folks still didn't know that we existed. And yes, there is a program. It's the Child and Adolescent Protection Center, CAPC for short. And underneath the umbrella of the Child and Adolescent Protection Center, there are a few different types of clinics that we have. The first one is our CARES clinic, which is the Center for At-Risk Evaluations. Our Dr. Catherine Dye, she has a special interest in commercial sexual exploitation. So in the CARES clinic for C-sex victims, otherwise known as trafficked youth, they present to that clinic. It's a combined clinic with the Adolescent Health Center and with some of the general pediatricians. We also have a program for sexual assault nurse examiners. And then our clinic, other than our medical providers, we also do have a pretty good full staff of mental health providers. Yes, ma'am. Yes, so the Child Protection Center is in this hospital. It's on the first floor down the hallway from the emergency department. It's right across the hallway from where Adolescent Health Center and Child Health Center used to be before they moved. We too are moving at some point, but we're still there right now. The CARES clinic used to be housed on site, but the CARES clinic has now moved to the Shaw location, but we still are centralized here, and the staff for these clinics are all housed here. So what's special about our team, or what we try to do when we're managing patients, is to remember that our care should be child-focused, victim-centered, and trauma-informed, which sounds like really nice words, but what it actually means is that in medicine, we tend to try to take care of the patient and families, and you know, we know a lot more about what's going on than the patient or family may know, so we tend to try to influence or get our job done and get the things done for the patient that, you know, are on a checklist or we know may need to be done. But when it comes to child abuse management, because of the things that these children have gone through, sometimes there are things that we know may be beneficial for their health, but for them emotionally or mentally at that point, you know, some things can be done tomorrow instead of right this second. So making sure that what's best for the patient, what's a better response to what they may have gone through, we structure our care around that versus just getting everything done that we need to get done right away. So the services that we provide in our center, of course, medical services. We do medical evaluations, provide treatment, forensic medical exams, and we also do consultation for other medical providers. Also for our community partners, investigators and attorneys. I'll talk a lot more about that in just a few minutes, but what a lot of people may not know is about all the mental health services that we also have. So all of our social workers are licensed clinical social workers, so they have additional training in providing clinical care and answering clinical questions. And because we work so closely with them, they get a lot of experience with the medical side of things and are really good at answering a lot of the more common medical questions as well, which will become important in just a minute. So aside from working with the physicians, the mental health providers also carry a caseload of therapy patients, and the type of cases that they take on include, some psychological evaluation, juveniles with problematic sexual behavior, so that means kids who are acting out sexually on other children, education in the community, providing trauma-based therapy, making referrals to other centers as needed. Yes, and when we work with them in the clinic, they also will do mental health intakes for our clinic appointments and crisis intervention on their backup call schedule. So they do carry a pager and help to answer questions during the day from folks who have questions, and then overnight as well. So child abuse, the diagnosis of child abuse is a multidisciplinary diagnosis. It's not solely a medical diagnosis. Of course, the medical team does make that medical diagnosis, but the meaning of it in the grand scheme of things has a lot more to do with an overall impression from all the different pieces. So the child abuse team here at CAPC, we are the medical arm for the multidisciplinary team, which is a citywide, set of different providers. Here on the left side, you can see the different components. So we have law enforcement, which includes attorneys and police, child protective services, and then there is a DC Child Advocacy Center. So these are a lot of words up here, but the United States Attorney's Office, or USAO, Office of the Attorney General, or OAG, Metropolitan Police Department, or MPD, and Child and Family Services, or CFSA. You'll probably hear some of those abbreviations moving forward, and all of these folks listed here work together to discuss cases. And there's actually an organized meeting that we have for our physical abuse cases twice a month. Sex abuse has a separate MDT meeting twice a month. There's also a meeting for trafficked youth, so there's different MDT meetings to discuss each type of maltreatment amongst all of the folks together to try to come together for a consensus. Within the Child Protection Center, like I said, we have mental health clinicians. We also have a victim advocate that works in our center. And then among the medical providers, there are 4 child abuse pediatricians, and we have a sexual assault coordinator who is our nurse who runs our sexual assault nurse examiners, or coordinates our sexual assault nurse examiners program. So these are all the folks on our team. Dr. Allison Jackson is the division chief. Dr. Hines, myself, Dr. Dyer, the pediatricians, Ashley, Lenise, Kyle, Megan are all of our social workers. Shelly, or Christian, is our nurse. And then we have our support staff as well, our manager, victim advocate, assistant, and staff assistants, Tawana, Siobhan, Crystal, and Vicki. So one of the major parts of our job, like I was just explaining, is to work with our community partners, or the MDT. And a question that I got was, how do you work with law enforcement on an ongoing basis? So pretty much more specifically what our job is when it comes to working with law enforcement is to take medical jargon, which we are probably is second nature to us at this point. There's lots of abbreviations that are written in medical records, and information that, or the way that things are worded makes sense to folks who read medical documents and are kind of in this life. But for law enforcement or for investigators, they may not understand, if somebody just wrote PRN, they may not know what that means. So what we do is translate medical jargon to English so that people understand what is in the medical record. Of course, we also help to provide an explanation about what the medical findings mean, and if there's any testing or work that needs to be done, we're like a liaison for them to the hospital. So we'll do our own evaluation, but we can also help to review the chart with them and provide updates or information about things that may be going on other teams or services, like if the child's in the PICU or there's a consult that was placed, those kind of things. So the way that we do that is communication. Obviously, we'll call and follow up with them when we have a case that we consulted on and review with them, share our documentation with them. There's lots of emails and phone calls that go on, but more formally during that multidisciplinary team meeting, we have a list of cases to review, and we go through each case. All the doctors are present and present their cases, and they can ask questions of us at that time. We have a radiologist that's present at that meeting as well. That helps us to go through radiologic images and just help have a platform to help them understand the cases that we have. So I have HIPAA exemption listed here, and we'll talk about HIPAA a lot more towards the end. But for our medical records, there is a HIPAA exemption for cases of child abuse that are being investigated. So I'm allowed to share my documents with the police without the consent of the parent. Obviously, you can understand how that would be protective, because if there is a parent who is a maltreater, they may not tell me that I have their permission to share their note because they don't want to get in trouble or whatever else. So I don't have to ask permission. It delays care, and they may not say yes in the first place. So by law, we're legally allowed to share information amongst any of the MDT members. It doesn't just have to be the police. It could be CFSA, anybody that was on that list, USAO, OAG. We're all allowed to information share with one another. So the role of the child abuse pediatrician, we're a subspecialty of pediatrics. So we all did general pediatrics residency. I did a fellowship in child abuse pediatrics specifically. My other two colleagues did not have to. The child abuse pediatrics fellowship is actually not new at this point, but a little bit newer. But it's a specialized field, so none of us do general pediatrics at all. We all do this full time. So I consider myself a child injury specialist, and that's typically how I'll introduce myself to families. As you can imagine, introducing myself as a child abuse pediatrician doesn't really go over that well. That's what the ABP has officially named us, but I think it's more descriptive to call myself a child injury specialist, because that's really what I am. I get called in to help out with cases where there's a concern about a child's injury and try to help figure out if it's an accident or if it's abusive. So all cases that I see are not abuse. Actually, there's probably more than 50% of them, there's just a question or there's a concern, but the diagnosis of abuse is not even something that's been made or will be made. We do our evaluations in a forensically sound way, which means that the way that we conduct our examinations and write our notes can be presented in court, and there's not an issue with how things were done because it's forensically sound, which means it's for the purpose of being provided as evidence. All right, so how often do we see this at children? So I just was looking back at the numbers in fiscal year 22 in CAPC. We participated in the evaluation of at least 383 victims. So that includes our inpatient consults, outpatient, clinic patients, case review, crisis intervention. That number is definitely not the total because of the nature of the work that we do. There are a lot of in-person evaluations that we do, but there's a lot of discussing cases for kids that we don't actually see or write a note on or are able to bill for. We do a lot of discussing versus actually having a full evaluation. So that number is definitely lower, but at least that many. For our acute sexual assault survivors, so those kids who needed like rape kits, there were 38 survivors that we served. And then for our mental health team, there were 16 new clients in the past year. They do have an ongoing caseload, so the total caseload is probably upwards of 30. And then 144 victim mental health intakes. So during our clinic visits, there were about 144 kids. So as you can see by these numbers, we are busy. This is not something that is rare and uncommon. We have things to do all day, every day. All right, so parts of the child abuse pediatrician's job, we do inpatient consults, like I mentioned. So if there are kids who are admitted to the hospital and their providers are worried about abuse or worried about a situation, they can consult us, place a official order in Cerner, and we all carry pagers, and we can do consultation that way. Outpatient consultation, so just meaning our clinic, it's not like a usual general pediatrics clinic. Our appointment slots are an hour long, and a lot of times we could use more than an hour for each patient, but we do have a schedule where people can call for an appointment, and we see patients on an appointment basis. Acute sexual assault evaluation in the emergency department, so our SANE nurses are on call and come in to see those. And of course, like I mentioned, chart review. If someone has a question, we can just write a document in the medical record without doing a full consult. And then we testify in court as expert witnesses. Nowadays, it's becoming more and more frequent. There was a little bit of a lull during the pandemic, but having to testify for these cases in court is definitely one of the major parts of our job. So the types of maltreatment that we provide evaluation for include physical abuse, sexual abuse, neglect, and medical child abuse. And here is just listed out, the different parts of each of those. So with physical abuse, most of the time, our physical abuse cases are inpatient consults, head trauma, fracture, skin and organ injury. A lot of that comes through the emergency department as well. With neglect, there could be medical neglect, physical neglect. We sometimes get involved in cases with kids who have failure to thrive, and then medical child abuse, which used to be called Munchausen syndrome by proxy. So if there's a concern that a parent is intentionally doing something to their child, then we can help with those cases as well. So for our inpatient consult, like I just mentioned, these are just, the basic, most common reasons that we get called. Of course, it's not limited to this, and we are here to help think through cases as well. Even if it doesn't seem like a patient needs a full consult, we can still, review the chart and discuss it with the team. I was asked, what is the procedure and who do you contact if a child disclosed? If a child disclosed sexual assault to you in the inpatient setting. And this does happen sometimes. So the first thing to do is to listen to what they have to say, allow the child to make their disclosure without asking them any leading questions. If any questions are asked at all, they should be open-ended. If you're not familiar with asking open-ended questions or don't have a lot of practice or feel uncomfortable, the best thing to do is just allow the child to say what they want to say versus cutting them off and saying, wait, don't say that, let me go get someone else. It is certainly okay to listen to what they have to say. And then it's very important to document what you were told in an official way, so in the medical record and some sort of note, using quotations as much as possible, so the exact language that the child used. If they say someone, touched their poo-poo, for example, you wouldn't want to change their language to vagina or their buttocks. You would want to use that exact language and just put it in quotation marks. Any disclosure of sexual abuse by a child 17 years or younger has to be reported to Child Protective Services, and the person who the disclosure was made to is responsible for making sure that that report happens. So that means that that person should report it themselves, or if there's some sort of setup where the social worker will become involved, whoever the disclosure was made to is responsible for helping to make sure that whatever the hospital's official way to have that done, the report actually gets made. And then of course, you can go ahead and call our team and we can discuss what to do next as far as evaluation, getting them in for an appointment, or anything else that's needed. All right, so for outpatient consultation, the major caseload that we have is for sexual abuse visits. Of course, we also do see physical abuse, and then those kids that we see for inpatient consults, sometimes they'll need follow-up, images, or, there's something else that needs to be done. So we'll do inpatient follow-ups and ED follow-ups as well. All right, so some of the questions that our team can help answer, this is just a little guidance / reminder for some. We do work very closely with the police, and we do work very closely with CFSA. So it gets a little bit confusing, understandably, what kind of things CAPC can actually help with. So we are a medical service, though we do a lot of, I won't call it investigating, but history gathering, because we have to do that all the time. But our job is not to solely get the history and sort through all the details, although that is something that we do for our medical purposes to know what type of treatment or management the child may need, or if there's anything else that needs to be done as far as workup. So with that being said, I always joke that I should have some sort of social work degree at this point, because I do participate in a lot of social working, but specifically the questions that the child abuse pediatricians can answer and should be consulted for is when a child presents, for example, with an injury, and it's unclear whether that injury is more likely the result of abuse or could it have been an accident. So we'll go through the history, we'll take a look at the type of injury that's there. There's plenty of literature about different, for example, fracture types and the likelihood of a certain fracture happening in a certain age group, and whether or not that's usually something that a child can do to themselves or on accident, or is it, like a 2-month-old baby who has a spiral fracture. They can't walk on their own, so that's more likely abusive. So differentiating between what injuries are more likely in the abuse category versus something that could have been an accident. Does the history provided match the child's presentation? So that's really a summary of what our job is. We take a look at what the parent or the caretaker is saying happened, and take a look at all of the injuries that the child has, or what injuries the child has, and try to understand if what the parent explained can cause the type of injury that the child has. If it can, then potentially it was an accident. If the history they're given is not really an explanation, then we become worried about abuse, and we write those kind of things down and review that type of thing with our MDT colleagues, as well as our colleagues within the hospital. We also help to direct what imaging may be needed, what screening may need to be done. For example, if a child comes in and they're of a certain age to the emergency department and they have a fracture and there's not really a history to understand it, there's a certain trauma workup that should be done. At this point, we have an order set for it, but sometimes there are some nuances that there may be additional workup that may need to be done, so our team helps to direct that kind of thing. So the things that we unfortunately cannot help to determine, we did put out an order through Amazon for a crystal ball. It has not yet arrived. It's been about 4 years since I ordered it. So until my crystal ball arrives, what I won't be able to help you answer is if a parent is lying, if a child is lying. I can't do an exam and have a mom come in worked up about her teenager and look at her genitalia and tell the mom whether the child is a virgin or not. I can't help you understand why a parent is acting suspicious or why they're acting funny. Those types of things are what we call subjective, and I can't actually. There's no medical test that's going to give me the answer to those types of things. What I also can't tell you is, if a family comes in and the father says that the child rolled off of the changing table. What I can't do is tell you what that changing table looks like in reality. I can tell you the description that the father gave me, but I can't tell you if the changing table even exists, what it looks like, none of those things. So that's why we need reports to be made to CPS or law enforcement, because they are the actual investigators. They're the ones who can go out into the community. They can go to the house. They can verify heights. They can verify furniture. They can verify, if there was a witness or if the child was in the care of some other relative, they can go talk to those people. All of those things are helpful information to me when they become available, but it's not actually my job to investigate and go get that information. So that's why it's helpful for that MDT meeting, because they can bring that type of information back to us and say, yes, I went to the house, I saw the changing table. Mom said that it was 2 feet high, but it was actually 10 feet high. So now this injury is making sense because of the scene investigation that we did, things like that. I could talk about this for a long time. There's lots of different scenarios, but just in general, our job is to stick to assessing the medical and physical examination with a dash of investigation. Another question is, why is CAPC only available on the weekdays when they are staffed 24/7? That is not actually true. We do have a consulting physician that is typically present on site during the workday, during the weekdays. On the weekends, we're not in-house, but we are available by backup. Like I mentioned before, our social workers are our first call, take our first call overnight, and then on the weekends. So if there is a medical question during that time frame, or if there's something that's needed, that person knows who the backup physician is, and they'll just reach out to that person. And it's structured that way because there are a lot of phone calls that we get that aren't really something that need a medical answer. A lot of times, there's discussion about, this is the way the child presented, do we need to call CPS? And our clinical social workers work with that kind of thing all the time, and they're able to answer questions like that because we have order sets for a lot of different things. Initiation of order set is something, that they can recommend, and by the next day, the pediatrician may be in, have results they can review and get involved in that point. Yeah. So structure of the CAPC visit, I'm referring to the outpatient visit. Well, I need to talk a little faster. Okay. So there's a mental health intake, and then there's a medical examination. So part of the intake occurs first, and that's when the social worker will talk with the caregiver, try to get more details about why that child is there, and then also speak with the child based on their age, kind of make an assessment of, does this child need to be in therapy? Are there any mental health referrals that need to be made? So they're, just touching base with the family to make sure, they do a certain screen for suicide. It's just kind of the preliminary part to the visit. And then the medical examination happens following that. So the purpose of the medical exam is to ensure the health of the child after an alleged abusive event. Of course, documentation of any other injuries or evidence that support the allegation. So that's where that word forensic comes in again. And then if we do, although we're not general pediatricians, because children who are victims of abuse are at risk for, other situations like, not having access to medical care, or not going to the dentist as much as they should, or not being up to date on their vaccines. We also do a general assessment for overall health, make sure kids have dentists, have a pediatrician, and do a little bit of a review of that part as well. So part of the exam includes the physical exam, of course, but then we also can do a colposcopic exam, which is something I'll show you in just a minute, and then any lab testing, we'll review what lab testing has been done and decide if any additional labs need to be ordered, or if there's any follow-up or treatment that needs to be arranged. During the actual exam with the patient, this goes back to the victim-centered, trauma-informed approach. We do as much as we can, not as much as we can, we do a lot of explanation before we even get started because of children's trauma that they may have endured. For example, in sexual abuse cases, being touched forcibly, not really having the ability to make decisions about their body. Being in that situation obviously can cause mental and emotional stress, and they can have a reaction to something, to another person touching them or looking at their body. So we, have a conversation about what exactly is going to happen in the exam, explain everything that's going to happen before we even get started at all, explain to them why the exam is important, and then, of course, allow them to decide what parts of the exam they would like to participate in. They are fully able to say, I don't want to do any of it, and the exam will be concluded. If there needs to be a reschedule when they're feeling better or started therapy, then all of those things can happen. When there is a concern where we really need to get certain parts of the exam done, we still will allow the child to have as much control over different parts of the visit as they can. So, who's actually present in the room during the exam, using drapes and covers to cover parts of the body that are not being examined directly at that point, different positions, just to make sure that they are as comfortable with the exam as they can be. So aside from getting medical results, there are a lot of mental health impacts of the medical exam and coming to see us. A lot of the times our physical exam is totally normal. That's actually the case almost all of the time, but we still do the exam, and it's still important because of the mental health impacts that it can have. As you can imagine, if there were a case where a child was sexually abused and they don't really understand their body just yet because they're too young, or they may have had an injury or an infection or something like that, to have a doctor look at you and say, everything looks normal, everything looks fine, that reduces stress. And sometimes you can visibly see the parents become less stressed out, kids becoming less stressed out just by saying your body looks normal. So I would say that, number one or number two reasons why we do these exams. Of course, getting lab results back that are negative is something that reduces stress. And then if there are questions that children may have about their bodies, about how sex works, if they're going to be able to get pregnant in the future, is this going to have any long-term impacts, we can address all of those things at that appointment. And of course, disclosure is a process, so most kids don't disclose every single thing that happened right at the beginning. Their kids need to feel safe about saying what it is that happened to them. There may be certain people that they're willing to talk to, some that are not. So disclosure as a process just means that pieces of information may come out over time versus all at once. So the medical visit is one of those important times where the child will have an additional opportunity to share what happened to them. Some of the common reasons for presentation: obviously, if a child disclosed that they were sexually abused, we do sibling welfare visits. So if there is a similar age sibling that is in the same house with an abuser, we'll do an exam for them. Some of the common reasons that are not actually related to abuse based on the literature that we'll get referrals for is a parent is worried that the genitalia appears red, and is that worrisome for sexual abuse? The vaginal opening looks too big, to check to see if anything happened, or the child is displaying what the parent considers hypersexualized behavior. Those types of visits usually are a discussion about what's normal, anatomy, how the body is supposed to look, what actually means sexual abuse is a concern versus what doesn't. But as far as a parent's mental ability to relax, those conversations, again, are important. So forensic, I've been throwing this word around for this entire presentation. What does it actually mean? So we do what we call forensic medical examination, so head to toe, but we do the examination and document the exam in a way that can be used as evidence for the police investigation and any subsequent prosecution. So that means if the document ends up in court and attorneys are looking at it, judges are looking at it, it'll hold up in that setting. Forensic evidence, similarly, are objects, specimen, photographs that can actually be admitted to court and are valid for judges and juries to review. So how do we make that happen? Here are some of the tools we use for the forensic medical exam. The top left is our colposcope, which is a camera that we use mostly for anal genital exam, but we also can use it for physical abuse if there are like bruises that we need to take pictures of, just because that camera is really, really good and it uploads pictures automatically, so we'll use it for that purpose as well. Our L-shaped ruler, when we're measuring cutaneous findings, to be able to have different dimensions measured easily, we use this L-shaped ruler in the pictures. So obviously, if you take a picture of something and the judge looks at it, he can't tell how big it is. Even if I say I measured it and it was 2 inches, that doesn't necessarily mean that it's true, but we use the measuring device so that every person who looks at that picture will be able to see, will be able to gauge the size of the injury as being the same number. Bottom left there is a traumagram. Sometimes we'll use this when we're doing a physical exam and a child has lots of marks. Just visually for the investigation, it's helpful to see where all of the marks are all at one time. And then here in the bottom right, we used to use like a big professional camera to take pictures for physical abuse, but they're so cumbersome. Sometimes it doesn't work, the focus, it's heavy. So we now have our iPhones that we use, and each of the physicians has our own iPhone, and we use this to take pictures. We can use Cerner Capture, or we can just upload pictures very easily to the actual medical document, which is helpful when we share our documents with investigators. So this one is mine. I put my favorite Winnie the Pooh on here. All right, so colposcopy, the purpose of it is, I mean, it's a camera mounted on a stand, but the purpose of it is to magnify the area of concern by a lot. So the anal genital area, the structures of the genitalia are very small. You can see them, you know, easily with your eyes, but using this, it makes things so much bigger. We're able to decrease the length of the exam because we can just take a picture, go back later, blow it up on our desktop computer, and take the time that we need to do the evaluation while the child is not physically undressed in front of us. That's part of that trauma-informed approach. And then if there's a finding of concern, instead of having to have the child come back for an exam or have another set of eyes come into the room to do a peer review, we can peer review photos instead of having the child to have to be in that position. So when we get calls about sexual abuse concerns, a lot of the time you'll hear our response, can we follow this child up as an outpatient? And what we're not intending to do is delay the care or not have to do a consult right then. In our clinic, we're really set up to do anogenital examinations in a way that is forensically sound. And that means that here on this, on our bed, you can see down here in front of Teddy. So he's my giant teddy bear that lives in my office, but on this day he was working and allowed me to take photos. But there's stirrups on our bed. Most hospital beds do not have stirrups. There are beds in the ED that do, that we can use, but when kids present there, but in our clinic, both of our beds have stirrups, which we really need to get a child in the correct position to see what it is that we're trying to see in the most efficient and effective way. And our equipment is here. So our colposcope, as you can see, is pretty big. So that's not something that we're wheeling around the hospital trying to do examinations with. And it's just easier for the family, easier for the examiner to have the child come to the clinic and have, you know, the mental health part, the examination part, and we have all of our equipment. All right, so results of the physical exam, like I said, our examinations typically don't show any injury. And there are a few reasons for that, but the question that I was asked was, what other resources, ways can we test, identify that sexual abuse or assault has occurred if it's past 10 days, and the labia is usually healed around that time. So the answer to that is if the exam is not done right away to look for an injury, after about a couple days, sometimes, you know, a day or two, that injury will be gone and we won't be able to see it. The tissue in the genital areas, like the tissue like on your cheek. So if you bite your cheek, after about a day or two, you realize, oh, it's gone, or you don't even realize at all because it heals so quickly. It's the same thing with the genital area. So our examinations for kids where injuries have healed, we just make sure that we communicate with our MDT members what that means and how it doesn't mean that there was never an injury there because it's not there now, how that part of the body can heal completely and very quickly. So the physical examination is useful for all of these reasons, but shouldn't be relied upon to decide whether or not an injury was ever present. So in this study, it's one of my favorite studies to cite by Kellogg. When we talk about a normal examination in a child who is disclosing sexual abuse, like penile vaginal penetration, how can that exam be normal? this study helps to support the fact that it can be. So there were 36 pregnant adolescent girls involved in this study, and when they did examinations for them, 64% had a normal or nonspecific finding, and there were only 5%, almost 6%, that had a finding that was diagnostic vaginal penile penetration. So of course these girls are pregnant, so we know that that did happen, but most of the kids in this situation either had a normal exam or exam where you can't really say definitively that vaginal penile penetration actually occurred. So we walk around saying a normal exam does not mean that nothing happened, and this is one of many studies that supports that. So beside pregnancy, is there any other way to prove sexual assault if it has been more than a few days, because we know the exam is normal so often? And honestly, there aren't really a lot of ways to prove it definitively. That's why we have to work with our MDT partners to gather information that supports that concern versus confirms it, like a videotape would, a video feed, what am I trying to say? A video would. So like we said before, the diagnosis of sex abuse is an MDT diagnosis. So as the medical part of that, the exam is normal a lot of the time, but in those cases where there is a diagnostic finding or a child has a positive STI test, that information is very, very helpful for the investigation. So we go ahead and do all of our evaluation in case something like that is the case. So to answer that question specifically, the findings that are diagnostic of past sexual abuse is if the genitalia did not heal completely for whatever reason and there's a scar left behind. That is exceedingly rare, but if a scar is present, then that would confirm that there was anogenital trauma. If there's a transection of the hymen all the way to the base of the vagina, which is just a description of one of the ways the hymen can appear that is consistent with trauma, and then in prepubescent children, if they have a positive STI test, then that is also diagnostic. So among boys, what's being done to increase reporting and decrease the stigma? So I like this question because it's definitely true that most of the patients that we see for sexual abuse are female victims, and we rarely see boys. They come every now and then, and what's the reason for that? Is the reason because boys aren't being sexually abused at the rate of girls? And the answer to that is likely that's not true. Boys typically present less because of fear of retribution. They feel like, you know, I'm supposed to be male or a man and I couldn't fight them off. I couldn't defend myself. I don't want anybody to know about it, so I'm not going to say because I feel embarrassed. Feeling like they're not able to protect themselves or protect others, and having that label of being a victim are all barriers to boys wanting to actually disclose that they've been sexually abused, even though the rate of sexual abuse in boys is likely much, much higher than what is reported. So why is the exam normal so often? So the first reason, number one reason, is because in a lot of sexual abuse situations, there wasn't any injury that happened in the first place. There are lots of things that are considered sexual abuse, but would not cause an injury. For example, if a child says that someone groped their breast, you're not going to have an injury from your breast being groped. So fondling is a form of sexual abuse, but the exam would likely be normal. If there was sexual abuse where a child is made to perform sexual acts on someone else, their exam would be normal. The list goes on and on for interactions that are inappropriate. An examination wouldn't show that that was the case. In cases where there were injuries or where there was penetration, the way that the female body is built, it's built to accommodate penetration. Otherwise, every time a female had a sexual intercourse, everybody would have an injury and it would be very painful. There'd be a lot less babies around. So the body is made to accommodate without having any injury. And then, of course, if there was an injury and the exam was delayed or the disclosure was delayed, then the injury may have healed by the time they come to care. How common is it that children are brought into children by individuals who sexually assaulted them or those who did sexually assault them? So, first of all, in our clinic, we don't allow suspected perpetrators to accompany children to their visits. So it should be 0. Sometimes that does happen, but the reason is if there's a suspected perpetrator in the lobby with the patient, when we're trying to give them an opportunity to disclose or share what happened to them, if that person is sitting right there and they know they're sitting there, they are not going to be truthful with us because they know they have to walk back out to that person. So they're not allowed to accompany kids to our visit. But additional statistics about perpetrators in general, they're most often known to the family, but not necessarily related. So the concept of stranger danger is not true. 30% are relatives, 10% are strangers, and perpetrators are most often male, even if the victim is male or female. If the parent is not a suspect in the assault, are they able to provide support in exams, or are all exams done with the patient by themselves? So parents are definitely allowed to come along, and kids who are older than 13 years old are actually able to consent for treatment and evaluation for their sexual and reproductive health independently. So we'll speak with them by themselves first and then ask if they prefer to have their parent in the room for support, and a lot of times they do. Even some of our older teenagers would prefer to have their mother or someone else in the room. We just give them that opportunity to say yes or no. For our younger kids, the parents will accompany them during the visit, but we do try to carve out at least a little bit of time where we can speak to them on their own in case there's anything that they wanted to share or wanted to discuss without their parent present. How do you deal with parents when talking about these topics? Number one, be honest. It is a little bit of a learning curve, or an interaction curve, should I say, when discussing child abuse concerns with parents, especially when you feel like you might be talking to the suspected perpetrator or the alleged perpetrator, but just being straightforward and honest and confident in what it is that you have to say or the task that you have to perform is just the best way to approach it. I've gotten feedback from plenty of parents where they've felt like medical staff have kind of been, shying away from them or treating them differently or, making them feel really bad. And, none of this, even if they're the alleged perpetrator or suspected perpetrator, it's not been confirmed in court. This is just what we think happened right now. So it's not our job to judge anyone right away, and just get our job done, ask them the questions that you need to. Of course, be patient with them if they have questions or concerns, and try to be understanding of what they're going through. When we do these types of consults, a lot of the times it's the worst day or situation that parent or family is going through, learning that their child has been sexually abused or physically abused. So parents are often emotional, and just trying to get through our day and get to the next patient. Parents can feel that, and a lot of times they just need a little bit more patience and a little bit more understanding from us. As providers, how do you deal with the emotional aspect of this type of trauma in the pediatric population? I get this question all the time: why do you do this job? Or how do you do this job, I should say. And I think the best answer is that the medicine of it is really interesting to me, and the psychopathology of it is fascinating. To talk to a parent who is a suspected perpetrator and listen to them explain in their version what happened or what didn't happen, and to have follow-up questions, and they are having to come up with, explanations that may not have happened, or it's just absolutely fascinating to watch them go through that process in front of you, and I find it very interesting. So I attempt to leave the emotional part of it somewhere else, because there's a job to do and need to focus on doing that. And it's interesting. Head trauma is something I like to learn about. Fractures is one of my favorite things to assess. So I just find the field in itself to be interesting. Of course, peer support, talking to folks who have gone through something similar. And then on my time off, I'm very protective of my days off, leaving work at work. Some of us have a special ability to literally leave, what we were doing, our kid in the PICU that we're writing a consult note for, and not think about it till I get back to work again, because while I'm at home, worrying about it is not going to fix anything or change anything. So taking care of yourself mentally and emotionally is very, very important. Okay, what are ways to emotionally check in on yourself? Ooh, I got to talk about that. So there is something called secondary trauma, which is emotional duress that results from hearing about another person's firsthand experience, which is literally the definition of our job. So some symptoms that that you may experience when you've had these types of interactions and it's starting to affect you is hypervigilance, hopelessness, avoidance of certain patient types, becoming angry, always tired, in a bad mood. You just have an emotional drain from it. So ways to prevent or manage it, psychoeducation, so learning that this is something that can happen and it's not, you having a mental or emotional breakdown or having, these things happen to you for no reason at all, that there is an actual explanation and a reason, and to identify that is definitely the first step towards managing and preventing it. Talking to other people about it is definitely my number one way. My poor neighbor, Dr. Hines, I sometimes will walk out of my office before I even get to her office. I'm yelling, Dr. Hines, so she knows I'm coming, has a heads up. She can turn her chair around and just like have that interaction that I need. And that therapy is very, very helpful to talk to somebody else who I know understands way better than even I understand, because she's been doing this job much longer. Having somebody who helps you to be accountable. So she and I and our office manager, Tawana, have been trying to help each other go home at night, not sit here after 5 and now it's 6, now it's 7. We've been trying to encourage each other. Okay, guys, what time are we leaving today? We need to go home and not sit here all night. Nutrition, exercise, all the other typical things. So acute sexual assault, we're going to try to get through this in 6 minutes. How many slides do I have? We have a lot of slides. Okay. So those are parts of the sexual assault evaluation. Do we still send the ASA patients back to the jurisdiction the event happened? And the answer to that is yes, in general, but there are a few exceptions. So for ASA patients, which is acute sexual assault or alleged sexual assault patients, if it is an acute evaluation, meaning there was a sexual assault within the past 72 hours, then they need to stay in the hospital and have their evaluation done if the assault occurred in the District of Columbia. Our SANE nurses are funded by, on this slide, by the Office of Victim Services Justice Grant here in DC, so they get paid to see the DC cases. The exceptions to that are if that child has been here for a long time, which has been happening because the ED is so busy right now. So they've been here for 16 hours already, and we're just now figuring out that they need to have this evaluation done. What we don't want to do is prolong that another 16 hours for them to get to the jurisdiction where it happened. So our nurses will do a courtesy evaluation for those types of cases. If a child is here and they need some sort of other medical treatment, like they need a procedure to be done or they need to be admitted, we're not going to send them away and have them come back. We'll just do the evaluation here. And then if a family is refusing to go and they want to have their kit done here, we can accommodate for that as well. All right, so if a child presents to the emergency department, the first thing that will be done is a little bit of triaging to figure out where the assault happened. So what jurisdiction. If it's in DC, then we'll get the ball rolling for CAPC to be consulted, to have the same nurse come in and have the pathway for all the labs and testing that needs to be done for them. If it's outside of DC, then we'll go through that checklist of exceptions for why they would stay. If there isn't a reason for them to stay, then we'll contact the jurisdiction if the detective is not already assigned to figure out where that child needs to go to have their sexual assault kit. So what actually is a kit, otherwise called a physical evidence recovery kit or a PERT kit? It's just a package of materials that have everything that's needed to collect evidence. Someone who's trained to collect that evidence, which are sexual assault nurses, to package everything up and then ultimately send it off to the DC Crime Lab for processing to see if there is any DNA foreign to that child on their body that can help to identify the perpetrator. So it looks like this. This is just an image from the internet, but most kits look similarly. So there's lots of envelopes and packages, cotton swabs, and the way that the examination is done is is outlined so that the maximum percentage of getting an actual DNA recovery is obtained. Our kit for DC looks like this, and it's in a box, and all of that stuff is packaged within the sexual assault kit. There's lots of information on the front that has to be filled out by the SANE nurse. But what's important as far as the investigation goes is the chain of custody. So there's a portion down at the bottom. You can see where whoever completed the kit will fill out their information, will store the kit if the detective is not on site, and then when they pick it up, they'll actually sign so that when it gets to court, nobody's able to say that, oh, well, it wasn't, you know, the alleged perpetrator's DNA in there. Somebody opened the kit and put their DNA in there. There's actually a way to verify if that could have happened based on who have possession of the kit. How long does it take? Long story short, a long time to do this evaluation because of the process that I just explained to you. First of all, the child has to get to the ED, has to wait in that line to register. There has to be a triage that's done, preliminary exam. The SANE nurse will get called. The SANE nurse isn't on site. They come in as needed, and they have to make it in from home, set up all their stuff. Then the child has to go back to the emergency department and get all their blood drawn. They get discharged from the emergency department, but the SANE nurse will get the child from the emergency department and bring them to CAPC because of, you know, our bed with the stirrups and the colposcope is there. Then they have to walk back down the hallway. So there's a lot of things that have to happen before the visit is over. So it can take a few hours, even if things run completely smoothly. How are minors and cognitively deficient patients represented in cases that they do not understand? So a legal guardian in those cases can provide consent. At this point, there are victim advocates that also help out, which is something that has been legislated legally in SABRA, so the Sexual Assault Victims' Rights Act, which states that any victim in the District of Columbia has the right to have a victim advocate present, which is someone who is assigned to help navigate the process, because there are lots of parts of it. So the medical part, they're there. They can listen in on, you know, what follow-up is needed, medication. They can talk to them about how long the court process will take, help with phone numbers to contact their detective. There's just a lot of different parts that are very confusing, and the advocate is there as an expert in that process to help guide that person through those things. Should you ask parents for old diapers to get samples? Long story short, no. The only reason that would be useful is if a child were sexually assaulted and the diaper that the child had on proximate to when the assault occurred was still available. Maybe there could be DNA recovered from there, or maybe the diaper that the child has on right then if the assault occurred recently. But other than that, we don't use diapers to obtain samples for gonorrhea or chlamydia or things like that. It would only be useful as potentially something that would be sent to the crime lab, but there aren't any medical tests that would be obtained using a diaper. Why is the forensic exam held off until people go to the clinic versus doing it in real time in the ER? Here I've outlined what the job of the SANE nurse is, what the job of the ED provider is, and what we can offer as an outpatient. And that first line, you can see we all do a history and exam. And the ED, for an acute evaluation, obviously CAPC is not open at that time, but they obtain labs for screening for STIs, which needs to be done for acute evaluations. But for our chronic patients that we see, they also may need lab testing, so we do that at CAPC as well. Our SANE nurse get called in for colposcopy, which is something we also do for outpatient visits, even if it's not an acute evaluation. And then at the bottom are the differences. So the SANE nurse is responsible for collecting the sexual assault kit, not the ED provider. And the ED for acute evaluations, you know, they'll give post-exposure prophylactic medications for multiple different STIs, including HIV, pregnancy, prophylaxis, HPV vaccination. All of those things should not be delayed until the child follows up as an outpatient in clinic. They need to be done urgently. So the ED takes care of that. And then for the outpatient, what we offer in addition to what the ED would give is, of course, the mental health intake, because we have a lot more time. We make referrals that may be needed. We write prescriptions if any lab tests came back positive, things like that. So mandated reporters, we're almost there. we're all mandated reporters here in the hospital. So physicians, nurses, anybody who works in the hospital as a medical provider, medical adjacent, we all are mandated reporters. How can nurses get involved at Children's? Become a SANE nurse. I think that's a great idea. The training program that we offer through our clinic is based on the protocol from the International Association of Forensic Nurses. We do have 24/7 coverage. Right now, I think we have about 8 SANE nurses on call to alternate shifts, usually 12-hour shifts. It can be broken down less than that, though. The coverage is paid, of course, by the grant, and you're paid just for covering. There's an additional amount that's given if you actually have to come into the hospital. Any nurse here at Children's can participate since you're already an employee. All of our nurses are Children's nurses already, and this is just like an additional job that they do. So feel free to join us if you would like to. What if you are not sure, but you kind of suspect foul play, but you don't want to make the wrong assumption? So the law here in DC protects against reporting suspected child abuse if you're reporting in good faith, which means that you had a reasonable suspicion that something happened, like the child said something to you or you saw something. Those types of things you will not get in trouble for making a report for, even if it turns out to be nothing. If a parent is upset about it, that you can't be prosecuted for making a report in good faith. But you can be held responsible if child abuse turns out to be something that happened and you knew about it and you didn't say anything. That type of thing is a misdemeanor in DC. So don't not report. If you see something, you can get in trouble. So to knowingly and willfully fail to report is a misdemeanor. Of course, for the sake of the child, if you don't report suspected abuse and the child is abused, then the outcome for that child can be negative because that report was not made. They can be made anonymously. You don't have to say your name. You don't have to tell them at all who you are. You can just describe what your concern is and give as much demographic details about the situation to the intake worker. And then following the report, the parents won't know who you are. Even if you do provide your name, that information is confidential. So like I said before, HIPAA permits us to disclose information about the guardian to the report, so you don't have to worry about providing medical information to the hotline because there's an exemption for that. So after a CPS report happens, so first the hotline call happens, an intake social worker will take down the concerns. CPS will decide whether or not they feel there needs to be an investigation. If they don't, it'll be screened out. If they do think that there needs to be further investigation because the concern sounds legitimate, a CPS worker will be assigned. And then after that, there's a long process in between that, but ultimately services can be put in place and the child is removed from that home, or there can be services in place while the child stays in the home. And by services, I mean parenting classes, drug classes for caretakers, things like that. Expert court testimony, so we don't testify in court as being on trial for what we did or what we said. We're just explaining all of the medical information to the judge, giving our expert opinion based on our experiences and what the literature says, and then, of course, explaining the documentation by other medical providers. I think this is the last one. So how often do we actually go to court? Actually, quite a bit. We get quite a few subpoenas. They don't all end up with us physically in court. Dr. Hines is actually in court today, and I have court next week, and the cases are just piling on right now. There's a certain part of the year where court is more busy, but there are different types of court cases that we testify for. So family court is just to determine safety. So does the child need to be removed? Can they stay in the home? Versus criminal court is if a perpetrator abused someone, are they going to jail? Yes, and those subpoenas can be delayed quite a long time. The case that I have next week is actually from 2019, but it certainly could be older than that. And this is our contact information. Dr. Teddy showed up again. He gets a lot of work done, but if you need to reach us, we are on SharePoint, so you can just look up our clinic and find all of this contact information that I have listed here. Our email address is super easy, capc@childrensnational.org. but all the rest of this contact info is available online, phone numbers and things like that. And that's it. And I ran way over. I don't know if there are questions, but like that our team would write. I like that you would write. Oh yeah. So all of our CAPC notes show up in the same place where any other consultant's notes would be. So you know, if you consulted dermatology, same place. So in the consult section, in the medical record. Yeah. So yes, so our notes are automatically confidential. So it may be, it will always show up in the consult section. There's not like a confidential consult section, but there are times where other providers will write a confidential note that's not typically protected. For example, I see a lot of times ED providers will have an ED confidential section that you'll have to specifically go to find a confidential ED note. But ours don't show up that way when you all look them up. It's only on the medical record side when people are asking for copies of the medical record. Our notes won't automatically get copies with the medical record. We actually have to review it and sign a release for those notes to go out. Anything else? All right, thank you all for your attention.